For 2021, it's going to be a complete change of thinking. Two big changes. One is the emphasis on medical decision making only, so less dependency on history and physical exam. Medical decision making, which in cancer care, that's incredibly helpful because if you've got cancer, you are already qualifying for a higher level visit because that's a threat to life or injury or death or wherever, and you've got typically infusion therapy going on. That's one change. The other change is they've changed the requirements on time. It required face-to-face time before, and now they've opened up the time elements for other people that may be involved in that care of that patient. It has to be the same day. So if you've got a medical assistant doing some initial work, and then a nurse practitioner sees the patient, then the physician, you can roll up all that time together. But systems, at least as best I can tell, are not geared to calculate time as they should. Because if you're going to bill based on time, you need a start and stop time as part of your documentation. And those type of things don't exist. The big scary one to me, though, is the emphasis on medical decision making, because physicians have not been their focus. They're looking at the 9 different physical systems, and then they have to say points on the different 9 systems to get the points to call it the appropriate level of visits. Likewise on history, there's 3 categories in the history. No longer. It's all medical decision making, and like you're going to have to really rethink the process. And I can see changes that may involve scheduling, staffing. I could see where teams may have to get really, like, throw out all the rule books. Let's start over and do things that make sense. The other big issue on the medical decision making, I have a very big concern regarding the chart note. If you're only going to have to focus on the medical decision making, how are you going to communicate to the family physician or the surgeon of why you're doing what you're doing if all you've got is one of the 3 criteria? That, again, is very unnatural, and it doesn't fit with what we've done in the past. Typically, if a physician gets a note, they're going to look at history. They're going to look at physical exam. What else is going on? Now, you're removing the incentive to do that. So what's a chart note look like? In some ways, it could make you free it up to be more flexible and more effective. But if you're not thinking that way, then you're not going to be a good communicator.